Okay, we're going to do a little tag team here because you do not do PCPCH 5-star accreditation as an individual. As Megan pointed out, it really takes a group effort. And so what we're going to do today is share some different perspectives in how we approached accreditation. So I'm going to talk a little bit first about some organizational readiness, because I think an organization has to be ready to support this kind of approach to work. Then we're going to have Cathy Simonson, who is our data queen, talk a little bit about the approach from a data perspective. We have Christine Mosbaugh, who we brought on a couple of years ago with the role to do patient engagement and communication. And it's been really transformational for us to really think about patient perspective in everything we do. And then finally, we're going to end with Carol Elchill, who's our site manager here across the street in East Lynn, kind of more from the clinic perspective, the kinds of things we did to get ready. You just got a quick little overview of who we are. In case you didn't know, we've got several sites, nearly over 10,000 patients, and a real integrated service delivery model. Because we're with the health department, so we really consider our services an array from person-centered primary care, oral health, mental health, all the way to population health services. So in our kind of getting ready to do the transformation and fully embrace patient-centered primary care home, one of the first things we did was really to look at how we would expand our care team. So the core team is your traditional provider, your medical assistants, your schedulers. But then for us, we really embraced the model of having a robust care team that included a panel manager, an RN care coordinator, a behaviorist, a clinical navigator, and a clinical pharmacist. And so these folks are all there on the team every day, working together to address the multiple needs of our patients. And this kind of gives you a little snapshot of how we thought about ourselves as integrating and creating connections within our own internal organization to the specialty services that we had available, mental health and public health. And we used, by bringing on some of the teams that are just right there in primary care, they also are part of connecting to the broader range of services. For example, the behaviorist works in the clinic 5 days a week, does a lot of behavioral health model, but they're also helping to link into the mental health, traditional mental health services. So that's an example of how we really bring integration to the care team. We really, in preparation, thought about access, because one of the criteria is you have to have expanded access. So we expanded evening hours at our sites. We started to use alternative methods for accessing, like using MyChart for communication and messaging, using our care team members to do visits. Sometimes patients will come in and just see the RN care coordinator, or they'll just come in and see the behaviorist. And it's a way to continue to manage the health, but not just through the provider schedule. The other thing that we focused on was follow-up after emergency room and hospitalization, because once we also were trying to help our patients access services appropriately. So trying to get them used to call us first before you just go to urgent care or the emergency department. Maybe we can get you in, and we have same-day slots always available. So those are some of the things that we did around access. We did invest in infrastructure. Data and reporting is critical to being successful in PCPCH 5-star status. You need to be able to document what you do. You need to be able to demonstrate your trends. And so we added a data person to our team when we were getting going, and they are foundational, and none of us could work without them anymore because they're the ones who help us to generate the reports, to have the data that we can track. And then the other focus area from an infrastructure perspective was really to think about quality improvement, and not just as an exercise over here, but how do we embed quality improvement in our thinking and in constantly improving and engaging the staff at all levels to think about how can we do this better and differently. I'm going to speak to, okay, so how do you afford to do this stuff? Well, that's always the big question, isn't it? One of the things that we did was we spoke up and participated in the alternative payment methodology pilot through IHN-CCO pretty early on. And what it did was detach the payment from a provider-driven visit to being paid a per member per month to manage the patient. And that shift I don't want to underestimate, because it really changed how we thought about things. It was no longer this kind of argument over the schedule and do we work somebody in and do we not work somebody in. Now we're paid to manage that patient. We can use our care team more fully. It doesn't have to be that provider visit or a busy schedule in order to generate the payment. It can be just managing that patient. So we started to look at alternative methods for visits, like group visits, using our navigators to make home visits, group visits. And so that really fundamentally made a difference and allowed us to think differently and support the expansion that needed to happen in order to make this work well. It created some financial predictability. It wasn't that kind of visit-driven treadmill that you find yourself in, but you know who your members are. You're motivated now to engage them, to find them, to keep them engaged, and that's a whole different shift in how we think about how we work. And those resources were also available to us and helped us support in innovation. We were very active in DSD pilots, and really taking the opportunity to try things new was really an important part of what I think made us successful. So with that, like I said, we're going to give you just a little peek into each one of these areas, and then we'll be open for any questions. So, Cathy.
Hi, everyone. I'm Cathy Simonson. I work at Benton County, obviously, what we call the SOS team. And we do a lot of data, we do a lot of processes, and we help our clinical teams use the EHR in an efficient and effective way, which all kind of ties into how we attest for PCPCH. So the Oregon Health Authority has a PCPCH website, and the Bible is their technical assistant guide. It is a lifesaver of details for what you need to attest. It tells you what each designation, each tier level, point-wise is, and what you need to do to achieve each point. Each standard has different sets of points that you can achieve. There are different categories within the attestation: access to care, accountability, comprehensive whole person care, which is where Sherlyn talked about our wraparound services that we have with the behaviorists and the health navigators, continuity of care. So we want to make sure that when the patients come in, that they're seeing who they expect to see. We try not to flip around and have doctors covering for one another quite a bit. So when they come in, they're seeing the providers and the staff that they're comfortable with. Coordination and integration. We want to introduce other services to them to help them be healthier individuals and lead healthier lifestyles. And person and family-centered care. We really reach out to our patients. We do CAPS surveys to find out what's important to them, how we can improve our services to make them more meaningful for them, and then we incorporate that in our day-to-day activities. Tiers and measures. There are 33 standards in PCPCH. Each have distinct point levels. You can reach a Tier 1 status with just 30 to 60 points, and that's with just passing the mandatory required standards. Tier 5, 5-star, takes a little bit more points, 255 to 380. You need to pass all of the must-pass standards, all 11 of them, and then 11 of the 13 offered additional standards that are specific for reaching star status. kind of hard to see, but this kind of goes through the 11 must-pass PCPCH standards, which includes telephone electronic access, performance and clinical quality, medical services, kind of outlines the services that you provide in your clinics, your organizational structure, how we track our patients' assignment to providers and their team so that the patients have that continuity of care, end-of-life planning, transitional care planning, language and cultural interpretation, and then the experience of care. So that's that survey where we're asking the patients how they feel that we're doing for them. The special measures that you need to achieve for 5-star or Tier 5 status are also, some of them overlap. So you might have a mandatory must-pass measure that's also a 5-star potential standard. So after hours access, that's where Sherlyn was talking about, we expanded our hours for after the 8 to 5 traditional hour set. Referrals are really big on not just sending people to patients to other providers, but actually doing the entire follow-through. Did you get the record back? Did the provider meet with the patient after they came back from the referral to make sure that the issue was resolved? The continuity of care, the responsibility for coordination of care, care planning, end-of-life planning, those are all part of the higher level standards that you need to meet for Tier 5. And documentation. Megan talked about this too. You really need to document everything. You need to have processes documented. You need to have policies documented, training for staff, and each attestation is at an individual clinic level. So we have 6 primary care clinics. We can't just do one attestation. We have 6 clinics. We do 6 attestations. Each are submitted separately, and each site visit is separate. There's some documentation such as policies that might overlap and be the same for each site, so we can share those at the organizational level, but each site visit is specific for that clinic in itself. To become a PCPCH, those new processes need to be documented. Staff training is very important. It's kind of a culture change, so you need to make sure that all of your staff are aware of your policies. The auditors will ask front desk staff, clinical staff, everyone that they walk into, questions about what's policies and how we handle certain things. So it's important that your staff be aware not only of their job duties, but how they integrate into the bigger cog of the whole system. There is a lot of reporting requirements for PCPCH, partly for the attestation process in and of itself, but partly as a QI process so that we can measure clinical quality outcomes and make sure that we're trending towards improving on clinical outcomes or some of these standards that maybe we didn't quite meet the last time around. Okay, and with that, I'd like to introduce Christine Mossbach.
All right, so I am here to talk a little bit about the patient element of PCPCH in the process. My role, as Sherlyn mentioned, is really to work with teams and organizational initiatives in the community. So PCPCH actually cuts across all of those fairly nicely. So I was able to bring in the ways that we value, reach, and engage those who we serve. And so while you're hearing a lot of technical pieces about why we do this as an organization, how we do it, what the data look like to do this, I think the part that I got to help focus on really was the people we do this for. And so I was able to tell our clinic story. We worked on getting our patient panel in, which is a requirement for this process. And so we really got to feature what it looks like as a patient, not just what we're trying to do, but how it feels and where our strengths are and where our weaknesses are. So I'm going to tell you a little bit about that process. The request and the requirement from OHA is that you have 6 to 8 patients or caregivers who are part of a panel. They should be representative of your population and able to speak about their experiences. So you choose who you want to come be part of your panel, but it's important, I think, to remember these pieces is that while you may get the opportunity to choose them, they are going to be asked questions about the whole range of experiences and surveys, and you want that to reflect the surveys or the services that you do provide. A note, while this has been the requirement for all PCPCH site visits, we have Spanish-speaking patients, as I assume many others in the room do. And so we said to OHA, well, if we're having patients who are reflective of our population, What do you all do about interpretation? So if people's primary or comfortable language to do this in is Spanish, what are you going to bring to the table so that that's possible? And they kind of scratched their head and said, I haven't done that yet. And so we have a really strong health navigation and translation space where we are. So we said, well, how about we do this? We will have a staff member come and do simultaneous interpretation for you all so that we can have somebody who speaks Spanish in their first language represented. And so that, I think, was a learning experience for all of us, but really helped us understand that that was an important population to include. Our clinic staff were largely the folks who chose the patients. They work with them daily. They know what their experiences are. They could help with that representative of the services that we provide piece. And so I put together some materials about what we would want and then got some patient information sheets out there. Some of our teams chose 25 patients for me, which was amazing, but just a few too many. We don't have space to do that, and it's just hard to have a conversation with 25 plus folks. So we were able to then really narrow that down to the 6 to 8 people who were available and who could come. And we all collectively as a team shared the responsibility of nominating and communicating with those patients on the day. At the time of the site visit, the visitors have about 45 minutes. There aren't staff, with the exception of that simultaneous interpretation example I gave. And they have some information that they share about what is a patient-centered primary care home. Do you know you're part of it? Has it been positive? What are the things you'd like to see different at your provider's office? They gave us both their good and their bad experiences, so it was very constructive and helpful for us. And they really structured it around the pieces that PCPCH and things like our CAP survey are looking at, which are listed under that experience of care. And at the end of the day, we had a debrief. And so as Megan mentioned, the whole team can be involved in this questioning process and information providing process. I thought it was really nice to see that at the end of the day, everybody who was still around was invited to be part of the debriefing process from the PCPCH staff. So it was pretty transparent about these are the things that you attested to, this is what we saw, we didn't see this, and just preliminarily how they felt about the day. They told us in almost all cases, I believe, the level that they were able to verify at that site visit. So we knew walking away, had we achieved 5-star status, would we be a tier 3, would we be a tier 4? And so that takes some of the mystery and the suspense out of the process, which was nice to realize after the first time or two. And then you wait for a little bit of follow-up, so that's not the end of it, but it's a nice introduction to what they had to say. And so just to show a little bit of the things that people said, they talked about being treated like people and not being judged, getting high quality care, having compassionate billing conversations, really having a referral process dialed in, being helped to understand their disease, and being made to feel special. And so these are the things from patients' mouths that the site visitors collect sort of in a report back to you that they then share, which were really nice. And to be fair to the process, they also shared things with us like your phone lines are really difficult to navigate, and at one of our sites we've had a handful of locums, and so that's kind of frustrating because I don't have the same provider all the time. And so they gave us a lot of things to work with, as well as nice things to hear about what we were doing well for them. And as I mentioned, there is a site report that comes out at the end, so you really know what happened in the process. There's not a whole lot of mystery, and it just is structured the same way that all the questions were and the attestations were, so around all of the different measures.
Hi, I'm Carol Elchill. I am a site manager for our clinic over here in the Twin Oaks complex, the East Lynn Health Center, and the one in Sweet Home. Because my 2 clinics were the first 2 to have the PCPCH attestation and inspection, they thought it might be appropriate for me to kind of go over some information with you all, let you know it was a fun experience. First one, not so much, but it got better. So primary care homes, I put this in here, we hear this word all the time. But it really means something more to the people who are looking at the information to verify that you truly are a patient-centered home. Home is someplace that you're safe, that you can go to, you can ask questions, you can be yourself, you can wear your sweatpants, nobody minds, right? So that's what they're looking for. They're looking for you actually have a relationship with these people. They know you, they know they can come to you, they can ask you questions, they can get help if they need it, they can come to you for answers. And we've been over this a little bit before. There are different levels for the PCPCH attestations. 5 is the advanced primary care home, the highest level that you can reach. So as a site manager, you're going to be, and you do this weekly, daily, monthly, you're going to be monitoring your provider templates. They want to see that your patients can get in to be seen by their provider when they need to be seen. If it's 6 or 8 weeks out, that could be difficult. And I cannot tell you if you don't have same-day access or some way to fit people in, that could be problematic. We also use panel managers who are referral coordinators, and they monitor the provider panels for patients that maybe haven't been in for a while, might need to come back, to try to keep them engaged and active. We look at quality metric spreadsheets all the time. And one of the things that they pointed out to us that could be more robust is PDSAs for your team. There's a lot of times you're doing PDSAs that you don't even realize it. Somebody says, well, what if we check them in this way, and what if I weigh them first? And if you make that a process and jot it down, then when the inspectors come, you can say, we've done 12 PDSAs in the last 6 months, and here they are. And that lets them know that your team is active and working together and doing processes, improvements for the better patient care. After hours phone message service is important in the fact that they want to be sure that your patients can get help when they need it, that there's some sort of resource available for them. So I brought one of my notebooks. It's quite the thing. You getting ready for the PCPCH inspection, you have a 145-page guide that you go through, and then you have to add the information in for your clinic that fits that and make sure it's all readable. The person who comes to inspect the site will need a book. You need a book, and your front desk or whoever is managing that end of it will need a book. So you have to do 3 of these notebooks and have them informationally correct with no PHI included. It took me about a month with some help to put them together because I can't work on it nonstop. So yeah, probably 4 to 6 hours a week for 3 weeks easily to get it assembled. If you have someone that you can dedicate to it, that's perfect. You want to create a site visit agenda, which I'll show you in just a minute, and get your team prepared for the site visit because they don't know what to expect. They're nervous. They're worried about what questions they're going to be asked, and there aren't any questions that they don't know the answer to. These people are nice. They're not trying to trick you or do anything to make life difficult. They want answers as to how you care for patients. And all the team know the answers. They just need to relax and not make a big deal out of it. That would be what my recommendation would be, is just to calm down and answer the things that you know, and you'll be fine. And as Christine pointed out, you're going to have your patient panel come and let them visit with them as well. And you want to have some sort of snacks or beverages because it takes probably an hour to go through all the questions. And just sitting there for an hour without something to drink is difficult. So this is a site visit schedule. You will need at least 2 rooms. The person who is reviewing the notebook will need a place to sit undisturbed. They may come out and ask questions, but they need some place they can read through that and look at things. They also will need some place to interview the team members. They go through front desk staff, the medical assistants, RN coordinators, if there are any, They just may ask questions of all the different team members and how they do things in their processes. It takes a village. We had all of these people present for the site visit, everyone that's involved, and they had questions for all of them. The health information manager was very important because she could open up the chart and help them look at things without, we didn't want to violate anyone's HIPAA privacy issues. And again, they have questions and comments for all of these people, and it took a process. So I wanted to point out my team over here, they got 5-star status. They have a really strong, really cohesive team. They've worked together for a long time, 5 years upwards, some closer to 10. They have a really good working knowledge of all the patients and what's going on with them. They practice good documentation. We have an on-site pharmacist, and they even sometimes go on home visits if they've got someone that they're really concerned with. The RN care coordinator or the behaviorist or both will go check it out and see if the provider needs to get involved. So that was pretty easy. Tier 3 for the Sweet Home Clinic, and it wasn't Sweet Home's fault, but we were using a lot of locums, and they didn't have a good working knowledge of the patients when they were questioned. Documentation was varied and really different among each of the locums. And so, and no on-site pharmacists, so they couldn't document proper patient engagement in that group. And I'm happy to report that we have a regular provider coming on board quickly, and I'm hoping to ramp it up, and we're going to start working on our 5-star status again really quickly. So the results of our clinics, East Lynn, Monroe, Lincoln, and Benton, the main clinic, all received 5-star. Sweet Home and our clinic in Alsea got 3-tier status, and that is partly because of not having a constant provider and a few other issues, but they're going to work on it. So, questions? Anyone?
So this question is for anybody on the panel, but what is the role of your physician or provider champions for doing this work? And in what ways have those champions helped or hindered the process?
Oh. For my team, my providers were both very much in favor of this. And to say that they are champions, they support the team fully, and they were very excited to be able to provide this for the patients and let everyone know what a good job we're doing. And I'd say that for PCPCH and the providers is probably the single biggest thing that I can see in this, is that it's a chance for your team to shine. They're already doing the hard work. They're already successful. They're already doing significant patient engagement. This is just a way to give them their Academy Award.
Second question, and this is somewhat related, but majority of practicing physicians and mid-level providers are still on fee-for-service in the state of Oregon. Going towards a PCPCH, especially 5-star tier home, we might need to change the payment methodology. So the question is, how successful can 5-star PCPCHs be if providers stay on an RVU fee-for-service methodology only?
Is that a loaded question? Honestly, I don't know that I agreed to go to the alternative payment methodology fully knowing all of the reasons, except I'm always kind of watching the horizon and see that's where it's going. It was afterwards that I I was struck by how fundamentally different you can think as a clinic manager, as an administrator, and it frees up the providers to think and practice the way they want to practice when you get off the visit grind. That's tough. And access that's driven by a provider schedule is tough. And so it created a lot of difference and a lot more financial predictability, because you have fluctuations in your membership. It goes up and it goes down. So I'm not saying it's like dollar for dollar, stable, stable, stable. But it's predictable, and you can manage it better. When you are in a visit-driven system, you're at the mercy of your patients showing up and coming in the door when you want them to. Now, we can go out and find them and bring them in if we need to. So it really, to me, is kind of an underappreciated, really transformational shift that needs to happen. And so I'm a big supporter of alternative payment, and I would tell everybody, stop worrying about it. And I think what made it successful on the IHN-CCO side too is that it wasn't just switching the payment, but in the course of the pilot, they were looking at things like access, our patients getting in. We started reporting our touches, not just our visits, and you could see how much more we were touching our patients through this care team. And then finally, we were expected to deliver on quality too. So it wasn't just a payment, reimbursement-driven thinking anymore. It was really about access and quality and being able to focus on that. I could go on, but.
These are questions for whoever on the team. Give me 3 examples of what group visit is. What kind of group visits do you have?
In some of them, we're still ramping them up, but we do diabetic group visits. We do chronic pain and Tomando control, which is the Spanish version of that. Trying to think of what else they do group visits for. Oh, yeah. Yeah, so our pediatrician does a lot of group visits with the children for BMI weight management classes, and our Monroe Clinic has been working on another diet and exercise group visit. So we kind of encourage innovation, and if somebody has a group visit that they'd like to try, and we can find an audience for it and find the space, we try to help that happen. But those are the main ones, pain and diabetes and weight management.
Also, what is a navigator's role? What does that mean? What do they do?
So we have a really robust health navigation program, and so there are currently, I counted yesterday, 31 people who are employed. There's a manager and 2 supervisors. The rest of them work either in the community, on a care team, in the schools, or in Samaritan clinics, actually. And they are people with lived experience who can walk beside patients. Many of them are bilingual, bicultural, and they are there to help people sort of fundamentally navigate the system, but also do a lot of work around social determinants. So if it's hard for somebody to get to an appointment because of transportation, they can help set that up. They can provide that. If they're looking for resources in the community, they are our encyclopedia of where to go. And I would add that in addition to just having knowledge, they have experience and they have relationships. And so they're a really key part of the work we do in terms of connecting people and helping them become healthier. There? Does that answer your question?
Yeah, I guess maybe we combine more of a care coordinator with that sort of a role.
Yeah, and so we do have care coordinators in addition. They have a very, I would say, from my perspective, at least different role. So they're doing more referrals and follow-up, and they're part of the medical care team. And our health navigators are serving a little bit more of a universal function in terms of coordination.
So let's just take diabetes. We have a diabetic educator that may start out working with someone who has a really high A1C, which means that their sugar's not controlled. If he's seen them and they're doing well, he'll turn them over to the health navigator, and they will continue. They might do some education around diet and exercise. They might go shopping with them at the store to help them figure out what foods are safe to eat, set up a cooking class for them, that sort of thing. We have to be a little more inventive in our resources, and so our community health workers or health navigators play a really wide role in the different things that they can do.
So kind of going off her previous question, I was interested in hearing more about what the panel manager does.
Panel managers, when we started out, we weren't quite sure, and this is probably 4 years ago when we started really using panel managers. Their primary goal was to go through the provider panel and make sure that the patients were still active and that we were doing outreach. So if they hadn't been in a while, if they needed an A1C test for their diabetes or something like that, we got a letter to them or called them. And it has grown to now they are also in most of the clinics referral coordinators. They go through the list of referrals on the electronic records, make sure that they have been followed up on, and either they abstract the results into the chart and get the information to the provider and then close the referral, or they let them know that they didn't follow up on the referral and close it out one way or another. So they're sort of the liaison between the rest of the team and the provider to make sure that things are happening that ought to be happening and that the patients who need outreach are receiving outreach. Does that answer your question? Okay.
I was just wondering what the difference is, or how the behaviorist supports the kids in the school-based health center around their other supports that they would normally get. So can you give me an example of what they would add to that school-based health center?
So I know what a behaviorist does, but not in a school-based health center basis.
So we have two school-based health centers, Lincoln and Monroe, and our behaviorists in both of those clinics kind of have that dual role of being our clinical behaviorists, but also network with the school and the teachers within the school to access resources. The schools, Benton County also has a contract with Trillium to place mental health, kind of more mental health promotion in the schools. So there's different resources for them, and so mostly it's just I think the main role is just linking to services, identifying when there's a problem and making sure that families get hooked in when they need that. Both of our school-based health centers are right on the school grounds, so we really try to have pretty close relationships with we don't see just the kids, we're seeing the whole family.
And I was just going to add that as sort of a clarification. So our school-based health centers are also PCPCHs. So we've gone to a lot of the others. I've visited a handful of them with our school-based health coordinator, and they're really just seeing kids. And our school-based health centers are seeing entire families. They're seeing other community members. And so there's a little bit of a hybrid happening just because of the role that the clinic plays in that community. And these are very rural communities or rural spaces sometimes, and so they're doing all in both.
And the physical setup, we have modulars on school property rather than a clinic within the school system itself, which allows us then to be more comprehensive in our approach. And I think it works well. Sometimes there's logistics involved in getting kids across the playground, or the high school's block or so down the road because we're on the grade school grounds. But our staff will go over to sort of maintain those connections to the school. But for us in those communities, it's really important to be able to serve the whole family and that community as well as the kids at the school.
Well, thank you guys all for coming. We were talking at our table that we're all now starting to prepare for next year's attestation. So this is kind of fun to, look back and see what we've been doing over the past couple years. I wanted to add a little bit to my introduction. I've been with Samaritan over 10 years, but I was hired to manage Samaritan Pediatrics in November of 2015. So I had the privilege of coming into the clinic kind of pre-pilot goings on. So I got to take over our attestation and kind of the process of wrapping up our pilot and then working with the state for our 5-star certification. We are the first Samaritan clinic to be awarded the 5-star certification from the state. So we took that as a very big honor. And I will give a plug to my amazing staff and providers, because really without them, and I'll talk about it in a little bit, and all of the integration that we've had from our system, there's absolutely no way we would have been able to receive that honor. So I think, kind of the admin side gets a lot of the recognition, but without our staff and our providers, it doesn't happen, because they're the ones seeing our patients. So just a little bit of background on our pilot and the project and kind of how we started. We had 6 goals when we first looked at building our pilot, really increasing the quality of care for our patients, but more importantly, engaging our staff within the services provided. The medical home, like Kim had stated, is about integration and coordination of care, and there were gaps in services just providing primary care within a clinic. So we were looking at what can we add and bring in that's really going to make this a one-stop shop for our kids and our families. The other things that we really focused on with our pilot and our 5-star were increasing our well child checks for our kiddos, nutrition consults with the addition of a dietitian in our clinic, and developmental screenings, as well as obviously obtaining our 5-tier 3-star designation. And then building care plans was a really big focus of ours and part of our 5-star attestation. Pediatrics didn't really have any when we started, and so we were looking at where can we build those in, what makes the most sense with the integration that we're bringing into our clinic. And then I think, as we all know, access to mental health is a huge challenge, barrier, and it continues to be currently, and that was something that we really focused and put energy into creating access for our patients. So with that, we added our dietitian, Kim Eisler, into our clinic. She's part-time. She not only does nutrition consults, but screenings, and then works with warm handoffs with our providers with kiddos needing nutrition services. We were able to bring a pharmacy consultant into the clinic to do best practices reviews to make sure that we were prescribing at the right level for our kids, as well as looking at cost savings. And I'll talk about that as we go forward. Healthy Heroes was a program that we developed in conjunction with our nutrition services and mental health. We actually kicked off our 3rd year of it last week, and we've been able to successfully coordinate and serve almost 50 kids and families with that program. Healthy Heroes is a 5-week program focused on teaching nutrition services, positive mental health and behavior change with kids. And then we also coordinate with Sam Fit, which is our Samaritan gym. And we have a trainer come in for 30 minutes and teach kids and families how to be active without necessarily incurring a cost to them. So we do a lot of focus on walking. We teach kids how to use pedometers, and we do active exercise in our conference room. We also do a healthy cooking class, teaching kids and families how to cook on a budget. All of our kids, when we first started, were IHN-CCO members. So really being mindful of the fact that finances can be limited at times, and how do we make the most out of what we have. A positive increase in CCO metric compliance was also a very big focus and acknowledged with our 5-star plan. We were able to end last year with a almost 90% well child check compliance rate, which was the highest in our system. And a lot of that was just really working with our providers to work those kids in and then additional outreach to our patients and families. And then a 70% improvement rate with mental health collaboration programs and outcomes. We are lucky now to have a full-time mental health specialist within our clinic, and she's available for the providers Monday through Friday, 8 to 5, to do intakes, crisis intervention, and then coordinates with our higher level mental health team. And that's something that's been integral to the success of our clinic. So a couple of the successes I just mentioned, and those continue today. One of the biggest parts of our pilot was making sure that we were sustainable after it ended, and we have been able to maintain all of the programs and services that we started with that. So we had our site visit from the state June 1st of last year, and we met in full everything that we attested to, which was really great. It was really fun and a proud day to bring the state in and show them what we were doing in our clinic. And they were extremely engaging, speaking with all of our staff, our front office, our providers, and then our back office and care coordinators as well. We were able to replicate a lot of the services that we provided in other clinics, and we are currently in the process of attesting to 5-star with multiple of our other clinics through Samaritan. One of the biggest things I kind of touched on at the beginning was the engagement of clinic staff and physicians. There's no way we would have been able to do it without them and their buy-in, and really being open to some of the changes that needed to be made to be able to reach that goal. We also focused on communicating what we were doing to patients and increasing the services so that they knew that they didn't have to go to multiple places to get some of the services that they needed. My care coordinator is amazing, and I wouldn't have been able to do any of this without her. So, and then constant review and assessment and checking in with ourselves. We do a lot of measuring, a lot of meetings to make sure that we are seeing what works, what doesn't work, and then reviewing. Workflows, quality improvement points, and process review are necessary. And I think involving your staff in that as well. They're the ones on the ground floor, so they know what needs to be changed and what doesn't work with patients and what does work with patients. And as we all know, patient responsibility is an equal component of being able to provide this level of service. So we received it on June 1st, 2017. We'll be reattesting to the 5-star status this coming January. And again, best practices and processes have been shared with other clinics preparing for their attestations as well. So some of the current efforts that we're doing right now, quality improvement projects surrounding immunizations and continued mental health follow-ups. We started a work group to ensure that our mental health services, from the time that they're referred through from our provider all the way up to the mental health providers, is a seamless process and that patients are being communicated with. And then we've been doing some work with the state through their AFIX program to increase our immunization rates. And then communication with patients, again, we found is to be the biggest key with increasing those numbers. And that's kind of our high-level review of our 5-star. I kept it short and sweet, so if anyone has any questions. So the question was, they came in June 1st, and when did we actually attest? How long did that process take? So we were prepping for the attestation to submit everything up until it opened. I think it opened January 1. We, I think, submitted ours mid-January. They reached out, I would say maybe a month after, and we wanted kind of the first slot that they had, and June 1st was it. So, yeah. I know in conversations with them now, since we have a lot of clinics coming in and they're getting audited or reviewed as the year's gone on, that they're trying to get out to all the clinics that they actually haven't been out to before they come back out and do re-attestations or re-site visits for ones that they've been to. So I'm guessing we probably won't see them again till later next year, but we'll be prepared if they come early. The question was, can I share an example of a real life example, a patient example, a positive outcome? So Healthy Heroes, I talk about it a lot because it's been such an impactful class that we've brought into our clinic. One of our first kiddos, he will remain nameless, but he's a he. not only was his family struggling with finances and getting in, but just nutrition compliance. There was some major health risk factors. He was over the 85th percentile with BMI, single dad. So kind of a different demographic than we're used to working with. And they dove all into our Healthy Heroes class. The dad actually stayed and participated with him as well. And he has now come back down into healthy BMI range. His labs have improved. And not only that, we've seen a huge increase in their responsibility in taking care of their own care. So they show up for their appointments. Their no-show rate has decreased. And a lot of that is the continued outreach and the things that we've developed through the pilot, as well as being able to have nutrition services on site with his provider. So he comes in for his well-child check, he gets his nutrition consult scheduled, and then he comes right back in. Part of the Healthy Heroes class for everyone who attends is a 3-month and 6-month follow-up to check on some of those kind of statistics that we're looking at. So has their BMI decreased into a healthy range? How are their labs? How's their weight? How's their compliance? And so some of those programs have really helped. We have a family this year, this is their 3rd year that they're doing Healthy Heroes because it's impacted them so much, and they said it helps keep them accountable, and they've really made it a kind of a family affair. We love seeing that because they're seeing how important this kind of education is. But being able to come to your doctor's office and have a class like that, I think has really taken kind of the fear factor away. Sometimes when we come to the doctor or the dentist, it's scary. Kids don't like to come. We think of it as we only go when we're sick. And Healthy Heroes has been a way to shift that mindset of doctors where you come to get healthy. And we can teach you some of the other things about staying healthy. And you don't just come when you have a cold. So, yeah. We have 1 care coordinator. We have just over 5,500 patients. And our providers have panels anywhere between 1,500 and 1,800 each. Part of our sustainability with some of the programs, so mental health and the nutrition, we had to kind of shift our payment models and figure out how we were going to supplement their salary. So Kim, our nutritionist, sees patients, and that's kind of how we make her work. Mental health's a collaboration and a alternate payment method between the 2 mental health and pediatric clinics kind of on our own side. Yeah. I will say the Healthy Heroes class and some of the other extra things that we do, currently those are all funded by foundation grants that we apply for every year. I didn't. So we run very lean. We have 5 providers, 5 MAs, and 2 front office staff. So a lot of what we did when we were implementing the outreach components was looking at workflow and designating specific times or specific ways of communication. And then again, looking back at assessing what's working and what's not, so that we're not spending a bunch of time or continuing to spend time on outreaches that aren't providing any results. And so we track all of the outreach that we do, the type of communication, and then how many appointments are scheduled from that. If we do all phone outreach, are we getting X amount coming back in? So we've had to do a lot of assessment like that. But it was changing some workflow, putting some tasks on other people. And our MAs, the way that our MA system works, we're a team-based approach, we're not one-to-one. And so that actually allowed for some help and assistance as well. So our mental health specialist is with us 40 hours a week. She has her own office and she does her own intakes as well. Then we have the full mental health team that comes in. We have fellows and full providers that come in 1 day a week to do med checks and kind of the higher level of care. And then any groups and classes are held at the family center, so outside of our clinic. But we try to do as much within the clinic as possible. And having that resource there, and I think most of our pediatric clinics now do, has been huge to be able to warm handoff. If the provider is in a room with a patient, being able to call our mental health specialist in and have her schedule an intake or speak with the family. She does a lot of phone follow-up and phone intake as well, which helps kind of, shift the care from not always having to be in person. I've had 1 MA leave in the last 4 years, and that was to go to nursing school. So My clinic really has had zero turnover as far as like front or back office staff. And if anything, they really enjoy the way and the shift that our clinic has moved to. I think the MAs being able to rotate through all the providers has allowed our education level to go up. They're learning from multiple providers, different types of practices instead of just being one-to-one. They also get to be integrated in some of the other things that we do in our clinic. So whether that's working with BFC, our AFIX program, we have someone who's extremely involved in safety, but they're allowed and have time to be involved in more than just one-to-one rooming. So yeah, every patient. So patient comes and checks in, they sit down, whichever MA is ready to go, grabs their ticket, grabs them, brings them back and rooms them, and we just rotate through. So they're working with all of our providers every day of the week and integrating with all of their patients. We do, all of them do follow-up calls for the providers. They all work on everything that you would do with one-to-one, they do as a group. It's definitely a different model, but it's been huge. And our providers, I don't know if they would go back, to be totally honest, to one-to-one. They really enjoy being able to work with everybody on the team. Yeah. And the way that physically our clinic is set up, our MA station is kind of in the central location of everything. And oftentimes, if you just pop into our clinic, and the state saw this when they came and did our review, the providers are there talking with them. They're sharing, warm handoffs between patients, and the MAs can talk about workflow. We also have residents that come in. One of my providers is an attending, and the residents sit with my MAs. So they're get to hearing that education and communication as well from the provider to the resident. So I love the way that our clinic's set up. It's really fluid. And I think that, often you're hearing best practices exchanged just throughout the day, whether it's provider to MA or MA to MA. And it's just really good open team communication. And the patients can see that when they walk out of the rooms, and they can feel that as well. So they send, when you attest, they send back pre-documentation and on-site documentation. So we created a binder. And I work together with our transformation specialist, which is a specific position that Samaritan has, and my care coordinator, designated physician, and my front office supervisor. And so we started to put together and send out pre-site documentation to them as far as the metrics that they asked us to meet. And then we put together a binder. And often a lot of the measures that we attested to, we wanted to show in person. And so we designated which ones we would like to specifically go over. And one of the things I loved about that was that everyone got to be a part of the on-site visit. My care coordinator got to present, my provider got to talk, my front office got to show off their things. So it wasn't just one person representing, I keep doing that because I talk with my hands. It wasn't just one person representing our attestation of what we were doing. It was really the subject matter experts and our providers, getting to share what they do, how we work, our workflow. Yeah, I keep that binder with me literally everywhere I go because you never know when you're going to need it. So I will say that model was in place prior to me coming, but my care coordinator was one of our providers' MA for 10 years. So she has been through the one-to-one to the shift, and it took a little convincing, but I think once you saw the workflow and the efficiency increase, as well as the ability for training time decreased, and the MAs really got to know all of the patients. We're very patient first, and I think that's how it should be. We have jobs because we have patients that need care from us. And I think that when we all approach it as a team, they're all our patients. Our providers all share call, so that helps as well. But yeah, I'm sure there was rocky bumps in the road like there is with any change in adjustment. But I talk with my MAs often, and I talk with my care coordinators often. None of them would change the way that we do it now. I think it's more efficient, and I think the flow of patients is better. Our wait time is less than 5 minutes for a patient in the waiting room. And every time an MA is rooming, it's the reintroduction of, hi, I'm Megan, I'll be your MA today. I'm taking you back, even if I just saw you last week. We're creating connection, we're creating fluid, and patients can call in and know that no matter who their doctor is, they're going to get seen, they're going to get taken care of. Do we have standardized workflows for rooming, how providers prefer to do things? And the answer is no. I wish that we did. I would say the closest that we do have is that most of our providers' scheduling templates are very similar. They all have their own preferences, absolutely. I think as we all do for everything, but there's standards that we follow for some things, but every doctor likes to do things a little bit differently. And again, like I said before, the education and the training increases when you're working with 5 different providers. You're learning all those nuances, so really you're kind of prepared for anything. Yeah. But I would say 95% of our front office is completely, we do the same thing for every provider every day of the week. One of the things that we do on a regular basis, we have a back office meeting with just our MAs and my care coordinator. We also have a provider meeting and then an all staff meeting. Communication is key, and when you engage them and push them to communicate and push them to work through some of those things, you can make those changes happen a little bit better. There's always ways to improve, there's always ways to do things, and everyone's gonna have preferences, but how can we serve our patients in the best way possible? That's kind of our focus that we always go back to. Everybody gets their lunch, everybody gets their breaks. We don't have any open positions right now, but I will let you know when we do. Yeah, we absolutely do. Yeah, that's super important. You gotta have the balance throughout the day. We do a lot with our patients, and there's a lot of energy we take on every day, so you gotta have your break and your lunch. All right, thank you.
Okay, well, that concludes our presentation. I wanted to thank all of you for coming and hoping that you gained some really good information to take back to your own clinics. I wanted to thank our presenters from Benton Community and also Megan, as she is gone, just to give them credit one more time for being our only 2 clinics that we're contracted with through Intercommunity Health Network that are at a 5-tier PCPCH. So that's incredible. As you can see, it's a pretty rigorous process, and as you well know. I also wanted to just add that we will have this presentation available online on our Intercommunity Health Network CCO website. So if any of your staff were not able to attend, or if you wanted to grab some information later, this was very thorough, so I think it will be available for you. And with that, again, thank you for coming, and hope you have a great rest of your day. Thank you.